All right, so today we're still talking about giving birth. Um, as I mentioned, we're going to talk about some different aspects of the normal birth process. Let's begin by talking about normal labor and what starts labor. Well, the answer in that is we don't really know. We don't know why labor starts. We have theories, but we're not really sure what causes labor. There's actually a lot of belief that labor is caused by a whole bunch of events happening together. Some think that as the uterus enlarges and starts to stretch, it starts to irritate, and then eventually it's going to kick it into contractions. Some people believe that there's a progesterone withdrawal as opposed to an estrogen dominance. So sometimes they say as the estrogen levels increase and the progesterone levels decrease, that can facilitate start labor. We also have evidence of oxytocin receptors in the uterus that actually increase towards the end of pregnancy, so it makes the body more sensitive to oxytocin. So oxytocin is a hormone that's made by the pituitary gland. We all have it. Um, so it's a hormone that's thought to increase during just before labor starts. So not only do you become more sensitive to it, it's actually the hormone that can cause contractions as well. So that can stimulate some of the prostaglandin synthesis, and prostaglandins also lead to additional contractions in addition to what we get with oxytocin. It can also lead to cervical ripening, and that leads to progressive cervical dilation. So uterine contractions is what we need to help dilate the cervix and kind of push that fetus down through the birth canal. So again, we think it's just a cascade of events. We're not really sure if one is more important than the other, but it's kind of thought of all these things happen at the same time. Okay, next I want to talk about premonitory signs of labor. So before a woman actually goes into labor, her body's, oh, can you hear me okay? Okay, Tori, I think it's okay. I don't know what happened, but okay. Anyway, as I was saying, before the onset of labor, the woman's body is going to undergo some changes in preparation for labor and birth. And so these are some signs that can occur. Doesn't necessarily mean they're going into labor today or tomorrow. Sometimes these can occur in weeks beforehand. But our body does go through some changes. So first of all, in the last class, we talked about Braxton Hicks contractions, and we talked about them kind of being a warm up for when labor begins. So again, it's just like we wouldn't run a marathon without kind of training our body. So that's what Braxton Hicks contractions do. So they serve as a warm up. They're typically felt as kind of a tightening or pulling sensation on the top of the uterus. The thing about Braxton Hicks contractions, we call that false labor because it doesn't bring about cervical dilation and effacement. But they generally increase as you get closer to labor, and they can tend to be pretty uncomfortable. And sometimes it's hard to determine whether or not they're true contractions or Braxton Hicks contractions. Um, Another process that happens is called lightening, and this basically occurs when the fetal presenting part actually drops into the pelvis. And so sometimes you hear that called the baby dropped. Most women notice it because all of a sudden they wake up and breathing is easier and there's a decrease in any gastric reflux that they might have been experiencing. And usually with that drop or that descent, the women might notice an increase in clear, non-irritating vaginal secretions as well. And as I said, lightening can happen like weeks before. It doesn't necessarily mean that we're going into labor soon, but it is one of the things that happen before labor. We talked about the mucus plug, and there are cervical capillaries which are ruptured and release a small amount of blood that actually mixes with that mucus plug, and that's what we call the bloody show. Some women report a big increase in energy before labor, and we call this nesting because many women will focus their energy towards preparing for the arrival of the newborn. It's believed that the increased energy usually happens 1 to 2 days before the onset of labor, and it's thought to be the result of an increase in epinephrine release, and that's what's causing that as we have a decrease in progesterone. Another thing we might see is spontaneous rupture of membranes. So during labor, it's identified as SRAM, so spontaneous membranes. So rupture of membranes with the loss of amniotic fluid prior to the onset of labor is considered a premature rupture of membranes. So when we talk about spontaneous rupture of membranes, we're saying that the water broke and labor has started. But when we're talking about premature rupture membranes, this is when the water breaks, but labor hasn't started yet. So probably about 10% of women with term pregnancies will have premature rupture membranes, and generally their labor will start within 24 hours. But remember, any woman who thinks her bag of water breaks, we want them to come to the hospital because now we have a countdown. If she's ruptured for too long, we can start to get an infection come in. Um, One thing that a lot of people don't realize is even though, you feel like you've lost the majority of amniotic fluid when that amniotic sac breaks, you keep making amniotic fluid. So you get a continuous supply to just ensure some protection of the fetus until birth. So many people are surprised, oh, well, they had a big gush of water, but why am I still leaking fluid? And that's why they're still leaking fluid, is because you keep making it until after the delivery of the placenta. So again, after the amniotic sac has ruptured, they need to report to the birthing facility because that is our last barrier to infection. And once it breaks, we no longer have that and we can get ascending infections into the uterus. Okay, so if a woman's water breaks, whether it's premature rupture of membranes or spontaneous rupture of membranes, we're going to ask some key information. First of all, we want to know what color is it? Is it clear, which is normal? Is it yellow, which could indicate maybe an infection? Is it green? Green amniotic fluid usually indicates that the baby has actually had a bowel movement in utero. And when they undergo stress of labor, in some cases, if we have a complicated labor, sometimes they have a hypoxic event, and that relaxes the anal sphincter, which can cause passage of their first stool, which we call meconium. So that's usually what the green fluid can represent. Sometimes if they're term infants or maybe even post-term infants, that placenta starts kind of getting a little bit old. It doesn't transfer blood and oxygen very well anymore. So sometimes that can cause that hypoxic event, which causes the baby to have meconium stained fluid. So we sometimes aren't surprised to see that in older babies. We want to make sure that there's no odor. It's very obvious if there is an odor. It just smells infectious, like you don't have to be right down there smelling it. You can just smell it. We also want to know the amount. Was it a big gush? Was it a moderate amount? Was it scant? Depending upon where the bag of water ruptures, you might have a big gush. So if a lower leak in the amniotic sac, that's usually when you have the big gush. But some women might have a higher leak and it's more of a steady trickle. So we want to know the amount. And then we also want to know the time. So when did this rupture occur? Because ideally we want this baby delivered in the next 24 hours. So I always use COAT as an acronym because I'm from Canada, of course. So I always say color, odor, amount of time. But since I moved to Texas and one of my favorite foods is tacos, you can also use that for time, amount, color, and odor. So again, the longer the membranes are ruptures, it does increase the likelihood of acquiring an infection. Bloody amniotic fluid is also a concern, and we're going to talk more about that when we get to some of the more complications that might happen during labor and birth. Okay, so as I mentioned, Braxton Hicks contractions can feel a lot like real contractions, and sometimes it's hard to tell the difference between the two. We give generalizations, like usually if it's true labor, if you walk, the contractions tend to get stronger, closer together, whereas if it's false labor, you start to walk, usually those contractions are going to go away. Of course, in true labor, we expect contractions to get kind of closer together, get pretty get stronger, last a bit longer, whereas with false labor, we don't really have any strengthening or increase in the contractions. Now, as you can see, these are just generalizations. So it's really hard to tell sometimes if you're having Braxton Hicks contractions or true contractions. And so there's only one way we can determine whether or not it's true labor or false labor. If it's true labor, those contractions are causing progressive effacement, so thinning of the cervix, and dilation of the cervix, so it's opening the cervix. So if that's not happening, it's probably false labor. Okay, so a lot of women do come into the hospital in false labor, and what we do is we do a vaginal exam, and then we watch them on the monitor, and then 2 hours later, maybe we'll do another vaginal exam. And if their vaginal exam has changed, we'll probably consider them in true labor. If there's no change being made, it's probably false labor. So this is really the only true way that we can detect that. Yeah, so it's very normal to come in and find that. Some women come in and they want to have a baby, so they they can tighten their abdomen, and sometimes these monitors will show like they're having a square-looking contraction. But what they don't understand is contractions don't get you admitted. It's the cervical change that gets you admitted into the hospital. Okay, so one of the things I'm going to post shortly after this class is I'm going to post something that's called components of the birth process, or what's called the 5 Ps. And that just kind of talks to you about basically the powers that are needed in labor, the adequacy of the passageway, the adequacy of the passenger, also psyche, and maternal positioning. So I'm going to post that later today, and I'll send you a little note for it because it's very important, and it also really goes over some of those fetal presentations. So I'll post that later today. So let's talk a little bit about the physiologic effects of the birth process. So right now, let's just focus on the maternal response. So uterine contractions are involuntary. We can't make them happen. We can't make them stop. So we can't control these at all. Uterine contractions are usually rhythmic, and they're intermittent. And so they have a period of relaxation between contractions. So you have a contraction, it builds up, it gets to its peak, it starts to come down, and then you have a resting phase in between. And the rest period allows a period of relaxation between contractions. And basically with this resting period, the woman and the uterus muscles get to relax, and in this pause, now we get blood flow return to the uterus and the placenta, because during the contraction, we actually have blood flow to the uterus and the placenta temporarily reduced. So during a contraction, we're not getting any of that blood flow. And remember, that baby's getting oxygen from that blood flow. They're getting nutrients from that blood flow. And then they're also contributing waste products back to the maternal system to be removed. So we need this little rest period for this baby so that they can, number one, mom has a little break, but number two, that's when all the blood comes back and gets to the placenta, which then gets to the baby. The uterine activity during labor is usually characterized by some opposing features. So usually it's the upper 2/3 of the uterus that provides all the power and contracts to push that fetus down against the cervix. The lower part of the uterus is kind of like more of a lazy portion of the uterus. It just really has a very passive role. So as it contracts in the upper portion of the uterus, it's pushing it down to that passive area, and its only job is to stretch and dilate and kind of go up and around the baby's head. So that's the whole purpose of that part. The cervix is attached to the lower third of the uterus, and it's also passive. So as the baby starts to be pushed down and the upper part of the uterus during contraction is placing the presenting part on the cervix again, that's how it kind of thins and dilates. So I actually have a cute little video on there about module, and well, I can't remember what it's called, but anyway, it's the cute little video, and it's a childbirth educator demonstrating Braxton Hicks contractions and true contractions and how that they work or do not work to dilate the cervix or to make the cervix thinner, but it's a really cute video. If you were in my live class, I do it for the students, but at least I found a video for you since you're not in a actual live classroom setting. So I had talked about the uterus, and so you can see how this upper part of it is really the part that's contracting and pushing that fetus down towards the cervix. And then you see a picture of how that lower cervix just kind of pulls up and around the baby's head as the baby starts to come down. So again, really fun demonstration. And basically what she does in the video is she teaches how it's similar to pushing out and she uses a ping pong ball and a balloon to kind of show you that. And it's a really cool demonstration. All right, so let's look at the contraction cycle. So each contraction has 3 phases. You can see how it starts to build up. We call that the increment. Okay, so the contraction is starting to build up until it reaches its peak, or the acme, which is the strongest point of the contraction. This is when the contraction is the most intense. And then we have the decrement, which is now the uterus starting to slowly relax until it gets into that resting tone in between. So we talk about 3 different things when we talk about contractions. We talk about duration. How long are these contractions lasting? We talk about frequency. How often are these contractions happening? And then we talk about intensity. How strong are these contractions? So the duration of a contraction is the length of each individual contraction from the beginning to the end of each contraction. And so we express that in seconds. And very rarely do we have contractions that are exactly the same amount of duration. So we usually document it as a range. So if we went to maybe counted 3 contractions and measured the distance from when it started to when it ended, and then again another one with time it started, time it ended, we'll probably get a range like 60 to 90 seconds after we palpated 3 contractions in a row. So it's usually a range, but duration is always the start of a contraction to the end of that same contraction. When we talk about frequency, that's the period from the beginning of one contraction to the beginning of the next contraction. And you can kind of see these arrows in the picture that show you that. So it's described in terms of minutes. So remember, duration was in seconds. Now we're going to talk about frequency. We're going to use minutes. And it's usually presented as a range as well. So maybe we have a contraction every 2 to 3 minutes. Sometimes you can get them that they're all 2 minutes persistently, and that's fine, but usually it's going to be a range. Intensity is a little bit different. The intensity is the strength of the contraction, which when it's at its peak, we describe it as mild, moderate, or strong. And so how do we determine the intensity of the contraction? Well, basically, we put our fingers on the top of the uterus, which we call the fundus. And we kind of press down when we're at the peak of the contraction. And basically what we feel tells us what kind of contraction it is. So for example, if she was having a contraction and it was at the peak of the contraction and I was to press on it with my fingers, it's going to kind of feel like pressing on the tip of my nose, okay? There's a little bit of give there. If it's a moderate contraction, it's going to feel more like trying to press my chin, okay? So it's a little firmer, it's a little stronger. And then when we talk about strong contractions, usually it's going to be very firm. It's kind of like trying to press on your forehead. And so that's really, we don't sit there and touch our faces the whole time, but I hope you were while we were talking about this. But anyway, that's kind of how we determine the intensity of the contractions. It's just by palpating. Thanks, Alice. I wanted you to be touching your face, so that's good. Okay, so this is just a little memory aid to help you remember what's assessed during pregnancy and what we document in the medical record. So again, we assess and document the overall pattern of contractions that we describe in terms of duration, intensity, and frequency. Okay, so the video also talks about cervical dilation and effacement. So dilation is normally the cervix is closed, and as it dilates, it can go from 0 centimeters to 10 centimeters. And 10 centimeters is a rough guess. Usually we say the woman is complete when we can no longer feel a cervix around the baby's head. Okay, so let's kind of talk about it a little bit. When we talk about effacement, we're actually talking about the thinning and shortening of the cervix. So normally a cervix is about 2 centimeters in length, but as labor starts, it's going to kind of get thinner. So kind of, I always compare it to like going from the neck of a ketchup bottle to the neck of a mayonnaise jar. That's what it's supposed to do. So when you start to have these labor contractions, they're going to push the fetus downward. So its actual presenting part, which is hopefully the head, is pressing on the cervix. And that pulls the cervix upward. And that's how it becomes shorter and thinner as it's kind of drawn up over the fetus in the amniotic sac. When we talk about effacement, we're talking about an estimation as a percentage of the amount of cervix that's thinned. So we might say, hey, maybe her cervix is 1 centimeter in length from 2 centimeters. So we would say she's now 50% effaced. When the cervix is fully thinned out, it's kind of like a piece of paper, then they're 100% effaced. So you hear 20%, 40%, and that's just how much the cervix has thinned out. So 100% means it's completely thinned out. And then as that cervix is starting to be pulled upward and the fetus is pulled downward, that cervix is actually going to start to dilate, which, as I mentioned, we express it in centimeters, with approximately 10 centimeters being full dilation to allow the passage of the fetus. A lot of students ask, what happens first? Does it efface or does it dilate? And the answer is that they usually occur together, but at different rates. So here you can see on the left hand side of this slide, you see the top and the bottom pictures for the left-hand side, and that's talking about a pregnant woman that's having her first baby. We call those prima gravidas. It's their first baby. So generally, they start to efface before they dilate. But if you look over to the 4 pictures on the right, this is a woman who's had more than one baby. She's had at least 2 babies. If she's had at least 2 babies, they're called a multigravida. And they usually start to dilate before they efface. So these are just kind of generalizations, but to kind of know that they really occur together. All right, so the next thing I want to talk about, we talked about dilation, we talked about effacement. So the next thing I want to talk about is fetal station. So the bony pelvis is actually divided into 2 parts. We have the false pelvis and the true pelvis. And so the false pelvis is this winged portion, and it consists of the iliac and the iliac crest. And its sole job is to just kind of serve to support the internal structures of the abdomen. That's all it does. But the true pelvis is the lower portion of the pelvis, and it has a pelvic inlet and it has a pelvic outlet. And you can see some good pictures in your textbook of this. One thing we also see in the pelvis is they have these little spines that stick out in the true pelvis, and we call those the ischial spines. Okay, and they're located midway between the pelvic inlet and the pelvic outlet. And at that point where the ischial spines are is usually the narrowest part of the interior of the true pelvis. So when we talk about station, we're actually describing the descent of the fetal head through the true pelvis. And we use the ischial spines as a reference for that. So if the baby's head is at the level of the ischial spines, we refer to that as 0 station. So if we say the baby is engaged or the fetus is engaged, that means that the presenting part is at the level of the ischial spines. If the baby was above the ischial spines, it's -1, -2, -3, and then we say the baby's in Canada. The baby's so high up. But as labor progresses, that baby should actually start to descend. Okay, so again, at the ischial spines, we have 0 station. But as that presenting part descends further, we talk about +1 station, +2 station, +3 station. And sometimes, and when we talk about generally the +4 indicates that that baby is crowning, which means we can see the presenting part right at the vaginal introitus, and delivery is going to be imminent. So that's how we go. So a lot of times students might get confused of, is it goes Is it negative before the ischial spines or positive? And a good way to remember that is saying +4 on the floor. Okay, that's a good way to remember. So the lower the baby is, the closer we are to delivery. So a lot of times when you go into the labor and delivery setting, you'll see 3 numbers. You might see something like 380 -1. And that means they're 3 centimeters dilated, 80% effaced, and they're still at a -1 station. So it's not unusual to see that because that's how we document our exams. Any questions about that one? Okay, you have a much better picture in your textbook that shows you those ischial spines for sure. And we can feel those when we do a vaginal exam. We can feel the dilation, we can feel the effacement, and we can feel those ischial spines. What did they, oh, 80% effaced. That's what I was talking about. So it's almost completely thinned out, but not quite. So it's 80% thinned out. Okay, the other thing I'm going to talk about is the mechanisms of labor, and we call this the cardinal movements. And so in the little presentation that I'm going to post after that, I'm going to talk about these cardinal movements as part of that. But basically in a normal delivery, and as long as the fetus presents themselves in an occiput anterior, so that means they're head down, and the back of their head, which is the occiput, is facing towards mom. Okay, so they're looking towards mom's sacrum. We call that the occiput anterior presentation. This is the most desirable fetal position for labor. But anyway, if the baby is in that vertex occiput anterior position, the fetus is going to go through several position changes to help adapt to the size and the shape of the maternal pelvis. And these position changes are referred to as the mechanisms of labor, or what we call the cardinal movements. And basically what happens is first we have descent. So that's as the baby actually comes down into the pelvis. So when we say descent, we're talking about the fetal presenting part that has now gone through and it's at the true pelvis. When we say engagement, this means that the fetal presenting part, which in this case is the head, as its widest diameter reaches the level of the ischial spine. So when there is zero station, which means at the level of the ischial spines, we say that baby is now engaged in the pelvis. Then what happens is we have flexion. So babies' heads are usually, their chins are flexed, so their chin's kind of touching their chest, and that flexion allows us to have the smallest head diameter pass through the pelvis. So it just kind of facilitates delivery if we can have that. What happens then is we have some internal rotation. So the baby actually turns to allow the largest fetal head diameter to match the largest maternal pelvic diameter, which is kind of cool. Next, we have extension. So as that baby's head passes beneath the mother's pubic symphysis, instead of being in that flex position, you'll see that the chin comes up and they'll start to extend. Then we have an external rotation. So the fetal head to allow the shoulders to kind of rotate internally to again fit the pelvis. And then when we talk about expulsion, that means we've had a baby. So that's the delivery of the baby. And I do have a little video posted in your module that shows you those cardinal movements and actions, kind of just make it make more sense. Okay, so we talked about the maternal response to labor. Now let's look at the fetal physiological effects of the birth process. So what does the fetus do? Well, last week we discussed placental circulation and how oxygen and nutrients and waste products are exchanged between the mother and the fetus, and that all that occurs in those intervillous spaces. And we discussed how during a strong contraction, blood supply to the placenta stops intermittently at the peak of the contraction, so we have no exchange. Okay, so remember the importance of those resting periods between contraction, because that's when we have our placenta exchange occurring. So in a normal newborn with a healthy placenta, there is enough reserve that the fetus can tolerate these intermittent interruptions of blood flow. But if we had a compromised fetus with insufficient placental perfusion, they might not be able to undergo the stress of labor. And those are the babies we might have to consider doing a cesarean delivery, because later in this course, we're going to talk about compromised fetuses and the signs that show us that we have a non-reassuring fetus versus a reassuring fetus. So another thing that's pretty cool is in a healthy fetus, the fetal cardiovascular system really reacts quickly to some of the events in labor. And we're going to talk about fetal heart monitoring more when we get to module 5. But what you do need to remember is the fetal heart rate is quite rapid, and a normal fetal heart rate falls between 110 and 160 beats per minute. So that's your normal fetal heart rate baseline, between 110 and 160. The other thing too, in utero, remember those lungs are filled with fluid, and that's to allow the normal development of the lungs. However, when birth happens, we want this fluid to be cleared so that they can take their first breath in an extrauterine environment. So as a woman starts to get closer to term, getting closer to having the baby, production of the fetal lung fluid actually starts to decrease as they get closer to term. And this also helps the fetus to absorb some of that lung fluid. And then as that head and thorax of the fetus is compressed in the uterus, some more fluid is actually going to be expelled from their lungs. And then once they're delivered, that remaining fluid is usually just absorbed in the pulmonary and the lymphatic circulation after birth. This is just a fun slide where they kind of compare it to fishing as the baby progresses down and getting close to birth. So that's just a fun slide that you can print out and make bigger if it's helpful. The next thing I want to talk about is the stages of labor. And so I actually made one of those little doodly videos like I made last week for the discomforts of pregnancy that really explains the stages of labor and the phases of labor. The reason I made that video is because there's some people use different numbers sometimes for the different phases of labor as far as cervical dilation, and you notice that your ATI and your textbook are not consistent with that. So I really want you to watch the little video and go by those numbers. But just to tell you a little bit about them, again, the video I made, it tells you a lot more about the stages of labor. The first stage is the dilation phase. Dilation stage. So we go from 0 centimeters to 10 centimeters. So that's how it starts with the dilation, it ends with 10 centimeters. So that's considered the first stage of labor. And you'll see that the first stage of labor actually has 3 phases. We have a latent phase, we have an active phase, and we have a transition phase. So the latent phase is the longest part of labor, but usually it's the easiest. A lot of times the women come in, they're excited, yay, baby's coming. They're having contractions, but they're not too painful. Then as labor progresses, we hit the active phase of labor. And most people say the active phase starts at 6 centimeters. And usually that's when labor contractions are getting closer together, they're getting more intense, they're lasting longer. If the woman wants to have any type of pain management, this is usually when she's going to ask for some IV pain medication or maybe an epidural. Transition is the fastest phase, but it's the worst phase. So transition phase is usually just a couple hours, but the woman tends to have very intense contractions at this point. A lot of times you'll see perspiration on their upper lip. They might have complaints of nausea and vomiting. They might be complaining of rectal pressure because of the baby's head pressing against that area. So they actually feel like, oh my gosh, I need to push or I need to have a bowel movement. Okay, after the first stage ends at 10 centimeters, we enter the second stage. And the second stage starts with the maternal pushing. So once she's 10 centimeters, she can start applying force and actually push with the contractions to facilitate labor. Once the baby is out, that ends the second stage. So second stage starts with 10 centimeters and ends with the birth of the baby. At that point, we enter the third stage of labor. So the third stage of labor is after the baby's born, and it ends with the delivery of the placenta. Okay, so the placenta delivers and that ends the third stage. So the fourth stage is after the placenta is delivered, and then it usually accompanies the first 4 hours after delivery, which we kind of call the recovery period, and that's the fourth stage. But as I said, I made you a cute little video to help you more with understanding the stages of labor. Okay, so next let's talk about duration of labor. Well, duration is different for everybody. Some women have quick labor, some women have slower labor. So it's really different. In general, women who've never had a birth before, those primogravidas, they tend to deliver more slowly than women who've had given birth previously. So in general, we always see exceptions to this rule, but generally first-time moms are going to labor a little bit longer than moms who've had previous babies. So Paris, we call those women who've had a few babies, they're usually going to deliver more quickly, but each woman labors differently, and each pregnancy sometimes they labor differently. If we have a very rapid delivery, like a rapid labor, and it's less than 3 hours, and we call that a precipitous labor. So if they have a fast labor like that, usually we tell them with the next baby, just come in as soon as you start feeling contractions. Don't wait, because again, in a history of precipitous deliveries, the next one's probably going to be even faster. Um, just a little bit more about fetal oxygenation. So again, if we have too many contractions, that can actually reduce placental blood flow and fetal oxygen, nutrient, and waste exchange. So again, we don't want contractions to be too close together, right? We want to have that resting period in between. That's very important. Also, our baby's not going to get well oxygenated if mom's in that supine position. So remember, when she's lying on her back, that heavy uterus with the baby in it is compressing the aorta and the inferior vena cava. So we're not getting good blood flow back to the uterus and to the placenta. So again, this is why I really stress no one should be laboring on their back. Okay, they should either be on their side, standing up, lots of different positions, but not flat on their back. It's also important to just talk about some of the conditions that we see with fetal compromise. So if we kind of see some problems, these are what it looks like. If our fetal heart rate is below 110, that's considered fetal bradycardia. Or if our fetal heart rate persists above 160 beats per minute, we call that fetal tachycardia. That can lead to fetal compromise. Meconium stained fluid, again, that shows that the baby's had a hypoxic event in utero and has actually passed stool into the fetus. If we have that cloudy, yellowish, or foul odor to the amniotic fluid, that can suggest an infection. If we have too many contractions or they're lasting too long, that's not good for the baby, and we're going to have some fetal compromise with that. Or if the uterus doesn't relax at all, they have a contraction and it lasts like 3 minutes, this baby's going to get compromised because, again, they need that resting tone in between to get adequate blood exchange. If mom has a fever, that's associated with fetal compromises as well. I mentioned that we want to get this baby delivered before an infection sets in. If a mom gets an infection, she's usually going to have a fever. We're going to see the baby's heart rate rise above, so we're going to see fetal tachycardia, and she's gonna feel hot, and so if we see that, we know that this baby is compromised. So we're usually going to treat her with antibiotics. We're going to give her some Tylenol. If she's close to delivery, we'll probably just proceed with the vaginal delivery. If she's nowhere near delivering the baby, we need to get this baby out of this environment, and we'd probably do a C-section. Maternal hypotension can cause fetal compromise because, again, you don't have as much blood flow to the placenta. So maternal hypotension, again, can be caused by being in a supine position. Later, we're going to talk about epidurals and regional anesthesia. And one of the side effects of that is it can drop mom's blood pressure so she can become hypotensive. And we actually have medications that we can give to bring her blood pressure back up. But again, if you're not getting a lot of blood flow to the placenta, baby's not getting that blood flow or oxygen. Later on in the course, we're also going to talk about some different medical conditions, and one of those is gestational hypertension of pregnancy. And this can be associated, just like you have vasospasm in your regular veins and arteries. This can also happen in the placenta as well, in those spiral arteries, which supply the intervillous spaces of the placenta where that blood pools. So maternal hypertension can also lead to fetal compromise. So women often ask, when do I go to the hospital? And unfortunately, it's not a great science. We generally say if your contractions are increasing in regularity, they're increasing in frequency, duration, and intensity, go ahead and come to the hospital. It could be false labor because we don't know until we check them. So let's say she comes in and she's having contractions. That's great, but the contractions don't matter as much as the cervical change. So if she's having contractions and her cervix hasn't changed in 2 hours, we're probably going to send her home because she's not in true labor. Because remember, the progressive effacement and dilation is the only sign of true labor. Anytime a woman thinks that her membranes might have broken or her bag of water broke, we want them to come to the hospital. Sometimes these babies kind of run out of room as they get closer to delivery, and sometimes they give the bladder a good kick, and sometimes mom spills urine, and it's really hard to tell, was that amniotic fluid or did I pee a little bit? And we want you to come to the hospital no matter what. We have a quick test that can determine with 99.9% accuracy whether or not it's amniotic fluid. So we can do this little test. Basically, it's a little swab, cotton swab. We'll put it into the vagina. We leave it there for 15 seconds, kind of make awkward conversation. And then we take it out, we put it in a fluid medium, and we send it to the lab, and it tells us if it's amniotic fluid. If it's not, it was probably some urine. And also, women, when their water breaks, can be very different. Some women have a low break where it's that big gush of fluid, and some women have a higher break, which is higher up on the amniotic sac towards the fundus, and it's just more of a steady trickle. So it's not always the same for all women. Anytime a woman has vaginal bleeding that's not mixed with mucus, indicating it's the mucus plug, if they're having bright red vaginal bleeding and it's not related to the mucus plug, we need them to come to the hospital immediately. Something's not right. And the other is when a woman gets to be about 28 weeks or so, we start having her do fetal kick counts. And basically it's just picking the same time every day when the baby's most active and just making sure that the baby's moving. A vigorous moving baby is a sign of fetal well-being. So that's very reassuring to us. But if they haven't felt the baby move, that could be a sign of fetal compromise. So we want them to come in. Now understand that babies do have sleep periods, and they usually can last 20 minutes to 40 minutes. So if they say, I haven't felt the baby move in an hour, okay, maybe go ahead, have something to drink, have something to eat, put your feet up. If you still haven't felt the baby move, come on in, okay? But 20 to 40 minutes of no movement is not unusual. But as I said, we usually do it and tell them to kind of do it the same time each day when the baby's most active. Okay, so by this point in nursing school, you've learned how to do a comprehensive physical exam. And that's very important for labor and delivery as well. However, when a woman first drops in and thinks she's in labor, we do a focused assessment first because we have to do this focused assessment right away because we need to know the condition of the mom, the condition of the fetus, and whether or not we're about to have a baby. Okay, so our priority assessment is going to be a focused assessment. Once we know we have a little bit more time, then we would go on and do the more comprehensive assessment. But we start with a focused assessment. Signs that birth is about to happen can be grunting sounds, or you can see the mom's kind of getting red in the face. She's bearing down. Sometimes they're just kind of lean to the side and they're sitting on one buttock because the baby's coming. If they yell, the baby's coming. That could be a sign of impending birth. And then we also have women who might be crowning, which is when the top of the head is actually showing through the vaginal introitus. So we actually see the top of the baby's head showing. So that usually means the baby's at like a +3, +4 station. So that's our priority assessment. Is the mom okay? Is the fetus okay? Are we about to have a baby? Okay, and then we go into our comprehensive assessment if there's time. Oops, that didn't turn here. Bonk. Okay, so as part of our focused assessment that we just talked about, the first thing I want to know is her vital signs. Does she have any signs of hypertension? Because if she does, again, this could indicate that we have a hypertensive disorder of pregnancy. Does she have any signs of an infection? Okay, and once we determine that and we go on to the fetus, is what is the gestational age? Do we have a preterm fetus? Do we have a term fetus? Do we have a post-term fetus? When is your due date? We're going to figure out the gestational age. The other thing we'll do is what's called Leopold's maneuvers. And these are very hard to describe, but it's basically a series of maneuvers that help determine fetal presentation and fetal positioning. And the reason that's important is because we need to know where the best place is to hear the baby's heart rate. Okay, so we hear the baby's heart rate through ultrasound best through the fetal back. So we want to put our ultrasound where the fetal back is. And so Leopold's maneuvers help us determine where the fetal back is so that we can monitor this baby. And as I said, you have pictures in your McKinney textbook that kind of shows these maneuvers, but also if you go into your ATI, there's a video on doing Leopold's maneuvers. So make sure that you watch those because that's good information. The next thing we're going to make sure is, has your baby been moving? Because if she says, I haven't felt the baby for days, we're going to be very nervous about that. So later on, as I said in Module 5, we're going to talk about fetal heart rate and patterns, but we want to make sure that we have a reassuring baby. And then we want to get the status and information about the amniotic fluid, which you can remember is our COAT or TACO assessment. So color, odor, amount, and time. Okay, so we have to have all that information. So that's our focused assessment. And then we can kind of move on from there to do a more comprehensive assessment. Providing comfort measures. So this is also really important because if you're not familiar with this, it's called the fear, tension, pain cycle. So it's the thought that the more pain you have, the more tension you have, which causes more fear, which causes more pain. And it's kind of a continuous cycle. And so we want to try to break that cycle for her. And so we can do that by helping her to relax. Because if we can reduce tension, that's going to reduce pain, which hopefully can reduce some fear as well. So some of the things that we can do is making sure that the lighting's appropriate. I like to dim the lights a little just to help with relaxation. I want to make sure that the temperature in the room is good for mom. It doesn't matter what's comfortable for me or comfortable for anybody in the room. It only depends what's comfortable for mom. Keeping her clean, maybe doing some mouth care as well. So as I said, that fluid continues to come out. So usually we put some Chucks pads underneath, and we'll probably change them out every hour so she's not sitting on anything wet. Another thing we can do is make sure that she's up emptying her bladder every 2 hours. The bladder is actually positioned under the uterus, so a full bladder is kind of like a roadblock. It's going to prevent fetal descent. Okay, and so if she gets up and voids every 2 hours, she's keeping that bladder nice and empty, which is going to help facilitate labor and birth. Positioning, we want them in a variety of positions. Usually the upright position is the best, but we don't want them lying on their back again because we know that that can lead to maternal hypotension, but we want to have a variety of positions. We want to kind of get this baby to settle in different positions to help facilitate birth. We want to provide water, drinks, provide encouragement, and if necessary, provide pharmacological pain relief if that's what mom desires. And okay, so one of the things also that I posted in this module, you'll see it's a little article by Penny Simpkin, and it just shows some of the different positions that you can use for labor, which are really helpful. Okay, so what is the nurse's responsibility during birth? Well, first of all, we have to make sure we have a sterile table, so we have all our instruments if we needed, and then we have sponges, and we have everything we need to deliver this baby. We want to go ahead and clean the perineal area, so we just use soap, mild soap and water is good for that. And then when the baby's about to come, we want to make sure that we have an extra nurse whose sole responsibility is the baby. So they're the person that's taking care of the baby when they're born. And if we see any type of fetal compromise throughout labor, we probably want to get the NICU staff in the room as well. So neonatal intensive care unit people. After delivery, in the hospital settings, we usually administer a medication, and the one we tend to use is called Pitocin. So remember I talked about oxytocin, and that's the medicine that's the hormone that we create that causes uterine contractions. We can actually administer a synthetic version, and that's called Pitocin. So Pitocin is the synthetic form of oxytocin. So we can actually give that medication, and after that placenta is delivered, it just helps the uterus to contract, and that helps to control blood loss. If we have like a boggy or a flaccid uterus, we're going to have a lot of bleeding. We're going to have a postpartum hemorrhage. So it's very important that that uterus, it clamps right back up. And we'll talk more about that in module 3. As far as this slide, it just kind of shows you the sequence for delivery. So again, in the top right to the left, we see that they're cleansing the perineum with warm soapy water. And then as you can see, the second picture in the top middle, that baby is now crowning. And what you see the provider doing is they're actually providing counter pressure against the perineum. And that can sometimes help prevent tears and lacerations. So just by giving a little bit of counter pressure there. It also controls the exit of the head, so the baby's born gradually rather than just popping out, you know, and causing trauma to the maternal tissue. On the lower left to right, once the baby's head out, the provider actually feels for a cord around the neck, and we call that a nuchal cord. Nuchal is spelled Nuchal, but that means a cord around the neck. So they want to feel for that cord around the neck. If it's there, we need to take care of it, okay? So if it's a loose cord, we can actually slip it over the baby's head like we see in this picture on the lower left-hand side. If it's tight, sometimes we have to go ahead and double clamp the cord and cut it before the rest of the baby delivers. On the next slides, you can see that external version. So the provider's applying gentle traction on the fetal head in the direction of the mom's perineum. And then you can see that they're actually lifting the head towards the mother's symphysis pubis to make way for the posterior shoulder of the baby, and that delivers the rest of the body. So that's usually what you'll see. If the cord wasn't already cut due to a tight nuchal cord, usually the baby's placed on the abdomen. We start drying and stimulating the baby on maternal abdomen, and they'll usually put 2 clamps in, and then oftentimes they invite the support person whether or not they want to cut the cord. And then what we usually see is we'll see signs that the placenta is starting to separate. So it can take anywhere from 5 to 30 minutes for this placenta to deliver. But one thing that's important is we don't ever want to pull on the umbilical cord. We want to see the placenta start to show signs that it's actually detaching from the uterus, and then we can provide some just light traction of the cord just to help aid in the delivery. But we never want to be pulling on the cord. We can cause problems doing that. So we wait till we see signs of placental separation. So what are those signs? Well, usually we'll start to see a gush of blood. A lot of times you'll just start to see that cord getting longer because the placenta is starting to detach and come down. And usually what happens is the uterus will take kind of a globular shape, I guess, you know, round like a globe. I guess that's what I'm trying to say. So you'll see that uterus will actually kind of take on a globe shape through the abdomen, and those are signs that the placenta is starting to separate. So again, usually we just provide some gentle traction and then the placenta delivers. So responsibilities after birth, they include the immediate care, of course, of the infant as well as the mother. So as far as the infant, we're going to support cardiopulmonary functions. We're going to dry this baby. We're going to stimulate this baby. We're also supporting thermal regulation. We're keeping this infant warm. We do not want babies to get cold, and we'll more about that in Module 4 when we talk about the newborn. But it's really, really important to keep this infant warm. And we can either do that by having the baby in a preheated warmer, or just being skin to skin with mom, because mom's temperature can help regulate the baby's temperature. We also want to put some identifying bands. So we have this 4-band ID system. We have 2 little bands and 2 big bands. So the baby's going to get 2 of those bands, okay? And they're going to all match. They're going to have matching numbers. And so 2 will go on the infant, maybe 1 on the ankle, 1 on the wrist. And then mom's going to get the other one. So anytime mom and baby are separated, we always compare those bracelets together to make sure we're giving the right baby to the right mom. And then the 4th band goes to whoever mom designates. So that could be the support person, but it could be someone else. It might be her mother or her family. It just really depends on who they identify. The thing is that whoever gets that 4th band is the only person that's allowed to be alone with the baby while in the hospital. So that's a consideration. You can't go back and forth. Once these bands are applied, they can only be cut off, and you don't want to do that until mom and baby have been discharged home. As far as care for the mom, we want to observe for any hemorrhage. And again, we're going to talk more about that in module 3. We're also going to check her uterus. We check the top of the uterus, the fundus. We want it to be nice and firm. And we're also going to check the amount of bleeding that she's having. And we call that lochia. And again, we'll talk more about this in module 3. Again, we're going to continue Pitocin to just help that uterus to contract, and sometimes we might even massage the top of the uterus, the fundus, just to help promote firmness. And then of course we also want to promote parent and infant attachment. So the first hour after birth is the ideal time for bonding. The neonate is very alert and responsive at this time. We also want to provide privacy. Not a great time to have a bunch of people come in, because we call this the golden hour. This is the best time for bonding, that first hour after delivery. And again, we usually, if baby looks fine, we're keeping the baby skin to skin with mom. She can start breastfeeding at that point as well. And we can do our assessment while the baby's still in the mother's arms. And if she is breastfeeding, we want to try to get the baby on the breast in that first hour. But again, we're going to talk more about these postpartum and newborn things later on as the course progresses. And that is the end of my giving birth presentation. I have another short presentation that we can either take a break and come to, or I can just continue on. What's your preference?